Welcome to Modern Musings, conversations with the maiden, mother, and crone, where we look at ourselves and the world through the lens of the 21st century. Hi, and welcome back to Modern Musings. I am your hostess today, Cindy Murray, and I am here with Amber Jones and Kristen Blakely.
Hello.
Hello. And we are coming back to our discussion on Anatomy of an Epidemic by Robert Whitaker. This is a book we started some episodes ago that has really changed my opinion of the pharmaceutical industry, particularly when it comes to psychotropic medications. And so this is our fourth and hopefully final episode, if we can get through all of it today. And so last episode ended with a very tragic story about a young life that was cut short by some often overlooked side effects of a common psychotropic drug. And it was really heartbreaking, and it was very eye-opening to me to read that story. And it brings up the question that if the scientific literature has repeatedly shown that psychiatric drugs did more harm than good, and if those drugs did not produce the long-term outcomes that we were promised, and if disability rates are still rising, then why does the public still believe that we are living through a pharmacological revolution? In this episode, we're going to talk about the millions of children who have ended up on psychiatric medications. This is one of the most heartbreaking parts of this story for me. It was really eye-opening and really made me question some choices that I have made over the years. And it's a story about how the narrative sold to us by the pharmacological industry became so dominant, even when large parts of the scientific literature are telling a completely different story. Because if Robert Whitaker is correct in his assumptions in this book, then the most important divide in modern psychiatry is not between different diagnoses. It's actually between what is said in public and what is written in the studies themselves. I want to start by going back to the late 1970s. We've already talked about how the American Psychiatric Association came into power, how it was developed, and a host of other industry-related organizations. But in the late 1970s, psychiatry started to come under pressure from a lot of different areas. And one of those was a psychiatrist named Thomas Sass, who argued that mental illness was not a disease in the medical sense, which is what the psychiatry has been saying.
Yeah.
But he thought it was just a label applied to specific behaviors and distress. And I kind of tend to believe with that myself.
I know. I think of disease like venereal disease, something you can catch.
Well, yeah, something that has a pathogen.
You don't catch sadness from somebody else.
Right. Well, and
a pathogen.
Catch the saddies.
Yes. But usually a disease, you know, I'm using air quotes here, is caused by a pathogen, and we know the cause of that disease, and we know the vector of that disease, and we know we may not know the cure of the disease, but we know the long-term results of that disease. But in this case, a lot of that information is just completely missing because, as we discussed in the previous episodes, they really kind of defined the disease after they found what they said was the cure. So at the same time that psychiatry was being attacked, so they felt, by this other viewpoint, psychology and counseling fields were rapidly expanding, and they were competing directly with psychiatry for the same patients. So, as you know, psychology is not a medical doctor, but psychiatry is. So, and psychiatric hospitals were increasingly criticized as institutions of control rather than healing. And all you have to
Mm-hmm.
do is stop and imagine the schizophrenics, you know, shuffling around in a ward, and the hospitals using the medications
It's
to
a
control
different
it.
way of a prison. They're not
It is
criminals, but
right,
they're
but they are imprisoned
being imprisoned and
and
controlled because we
controlled by
don't
the
know how
medication.
to
Right,
help them control themselves
right,
so that they're not out of control.
right, right. The profession was really losing authority. And Whitaker's argument is that what followed wasn't just a scientific evolution, but an institutional rebranding. He says that he feels like the American Psychiatric Association kind of looked at this distress. They were losing patients. They were um, the median income for a psychiatrist at this time was about $70,000, which was actually pretty good. But when you look at it in terms of other medical professions, that was pretty low. And
Yeah,
so, I mean, you know, $70,000 wasn't very much.
very
and
low.
and then at the same time, like I said, the people who adhered to the idea that therapy could help, you know, counseling and therapy, you know, they were pulling those customers away from psychiatry, who was focused mainly on medicating to control
Mm-hmm.
or to help their patients.
Well,
So,
not everybody wants to be heavily medicated.
well, and that's a big thing too. So, so anyway, in 1980, the APA came out with the Diagnostic and Statistical Manual 3. And that is kind of the Bible of psychiatry for diagnosing various mental diseases and
yes,
disorders.
I own said Bible, but
Yes.
DSM-5 now.
Right, right. And it's this kind of put them into a theory of where they had symptom checklists instead of psychoanalytic interpretation. So before, you know, the therapist or the psychiatrist would analyze what's going on with the patient and kind of arbitrarily come up with the diagnosis or whatever. But in this case, they had like a listing for depression. And for depression, there were 9 symptoms. And if the patient met 5 of the 9 symptoms, then they were diagnosed with depression. And there were similar symptom thresholds for ADHD and diagnoses for bipolar disorder and schizophrenia and a host of other illnesses and disorders. So the public sees this as, oh wow, they've really come a long way with this scientifically. You know, they've got it all pinned down, and they can categorically and definitely diagnose a patient. You know, without it's less subjective. It's like very cut and dried, and so that looks like precision, right?
Mm-hmm.
But the critics of it noticed something else that was really important, and that was that there are still no biological markers that point to any of these diseases, period. And I'm using that word disease in air quotes. There are no blood tests, no brain scans that confirm the diagnosis, no objective laboratory confirmation. What changed wasn't really a discovery. What changed was a classification, which goes back to the label, to me, that's applied to behaviors in distress, right? But with that classification, they regained a lot of their authority. And you know, it's important to note here that, you know, they did do blood tests and brain scans and things when those technologies were available, they just didn't see any difference. And Whitaker talked about that in some of, and we talked about what Whitaker found about that in some of those previous episodes. So the chemical imbalance era really kind of started in the 80s and 90s. And psychiatry really embraced and adopted this biological idea that there was, that all these diseases were biological in nature. There's some kind of chemical imbalance that that caused it to happen. So, like depression was linked to serotonin. Like the person who had depression, it was because there was less serotonin available for them. Or schizophrenia became linked to dopamine, and bipolar disorder was another brain chemistry dysregulation. So all of these things, they started publicly announcing this, and the public believed it. That's the message is simple. Mental illness is a chemical imbalance, and medication corrects it. Period.
And that's what made kind of like a stigma behind mental illness, is that, ooh, chemical imbalance, there's something wrong with you if you have a mental illness.
Right. Totally, totally. But they even address some of that too, eventually. But this whole thing that came about was that even as that message about the chemical imbalance became a dominant thing in the public's eye, the research findings were not really that conclusive. A widely stated statement from the National Institute of Mental Health summarized. It was a summary that was done in the 1980s. Noted, and I'm quoting here: elevations or decrements in serotonergic function per se are not likely to be associated with depression. End quote. Let me repeat that because I think that's important to note. Elevations or decrements, that's ups or downs, in serotonin, I hate that word, serotonergic function per se are not likely to be associated with depression.
So it's saying that serotonin and depression don't go hand in hand.
They are not linked.
No, they're not really. No.
Neither too much serotonin nor too little serotonin is likely to cause or be associated with depression.
And depression doesn't mean that you have too little or not enough.
Exactly.
They don't define each other.
Don't have a chemical imbalance.
Yes. Even though that is the message that they're trying to say, is depression needs serotonin, whatever, So, so in the public messaging, the antidepressants were still frequently described as restoring that chemical balance, even though the National Institute of Mental Health said that they weren't likely associated.
Well, yeah, you would take the drug company's money away.
Well, yeah. And at that point, like I said, the National Institute of Mental Health is a totally separate institution from the APA, which is the American Psychiatric Association, or the pharmaceutical industry that's, run by Eli Lilly and all these other companies, right? So these are three distinct or, multiple distinct organizations. But, one hand is saying it's a chemical imbalance and the other is saying, no, it's not. So, but the public is still buying it that it is. And that's part of what Whitaker is saying, is that it doesn't make sense that people buy this when it's obviously not true. But as he describes, once a really simple explanation takes hold, it's really hard for people to let go of it. And I like to compare it to the idea of vaccines causing autism. So
I was wondering when you were going to bring that up.
Yep. So like back in the, back in the early 90s, I think it was.
Jenny McCarthy was one of them.
Oh yeah, there was a lot of them, but there was an actual study that was done that supposedly showed that autism was linked to certain vaccines. Now, it later came out, not even long after that study was reported, it came out that it was falsified data. The guy had been, he had left out certain things. He totally falsified everything.
Well, and a lot of people do that. If the money walks, they're going to leave things out.
The data talks.
Yeah.
Right. So the thing is, though, that even once that guy was outed and they came out with the truth, the people still believed it. There are still people to this day, 30 some odd years later, who believe that vaccines cause autism, even though there's lots of case studies that show that is absolutely not true. And so this is a very similar situation. Even though the studies have shown that depression is not linked to serotonin, that there is no chemical imbalance.
Off topic, I had to look it up, but that study that you talked about just now in the 90s, the author that did that study only looked at 12 children.
Yes, and I think he was paid by somebody to do it.
Probably the same pharmaceutical company that
he
wants
was
you
secretly
to
paid by a lawyer attempting to sue
that.
vaccine manufacturers.
Yeah, they're trying to focus on that instead of something else.
Yeah.
Or someone with a lot of
they're
money.
Not trying to
paying
focus
a
on the
lawyer
truth,
to
and that's
force a case.
That's one of the things that I always say. You can always manipulate the data. I tell this to all the time when she talks about things that her husband Mark would say about scientific data. You can manipulate that data to say anything you want it to just by changing what you report out of the results that you got. So anyway, okay, I'm going back in now. As I choked.
I said it sounds like education.
Yeah, probably does. But once, like I said, once you get that idea stuck in your head, people just don't want to let it go, and so that idea of that chemical imbalance just stuck. But here's the thing with Whitaker, though. He's not saying that the medications don't help. And I don't either. I think in the short term, I think they are very helpful. And but I think the big point is that the long-term outcomes of taking these drugs is it doesn't match what the pharmaceutical companies are selling to the public. And a lot of things they don't emphasize enough the dangers of some of these drugs, or what those long-term effects, the long-term negative effects. So not only is it not as effective in the long term, but it also can cause long-term negative effects. And they don't really promote any of that information. It's kind of like a little sidebar in the literature that nobody ever reads, because when you get a new medication, do you read all the fine print?
No. Right. I actually just discovered one of the side effects of my medicine as I was shredding like some old papers, and I stumbled across one of those original like pharmacy letters for my antidepressant.
Those are really depressing.
They're scary.
Depressing.
They're
the
scary.
Side effects.
Yeah,
they're scary.
Or if you see those commercials, like say, like if you do like the ad, like HBO Max or Hulu or whatever, and like half of those commercials are
for
about
medications,
and like they list all the side effects, and Jason and I sit there watching. We look at each other and we're like, why would we want to take this? Look at the side effects.
I know the one that gets me the most is the psoriasis, only because I have psoriasis and I understand it. I get it. There are people with psoriasis like on their face and like
or it's
impossible
so bad.
places.
It's so bad.
It's so bad that life is hard to manage.
Yeah.
But for me, like my psoriasis is not to that level that I want to take a medicine that has thoughts of suicide as a side effect.
Right.
To me,
And
that's
like
crazy. And I was actually talking to my friend about that because that is the first symptom listed on my Lexapro. On my Lexapro.
Yeah.
So literally the medicine that's supposed to be like preventing that is actually causing that.
And we'll
yeah,
talk
and if you take it like the wrong medication, and you were talking about diagnosis and stuff like that, if you are misdiagnosed and then they give you the wrong medication, then bad things like that could happen.
Or just not even necessarily being misdiagnosed, but it's finding the right one. That's what they always say. We've got to find the right one for you. So it's like trying on a bunch of shoes.
It is.
But you have to wear them for like 3 months.
Right.
Well, you remember like
fit.
20 years ago, gosh, was it 20 years ago? Maybe more than 20 years ago, when we were living together, and I was diagnosed with bipolar disorder.
Yeah.
And I've always been like really open about that on this podcast.
Right.
And I can tell you this, and I know I talked about it when we first started talking about this, that I've been through every medication.
You tried on all of those shoes.
Yeah, I tried on all of the shoes, and like none of them 100% work for me, but there are a couple that work. But I remember when the very first one, or maybe no, it was the second one that I was on, and it just kind of like put me in this huge manic mode where I cleaned the whole house, like scrubbed it up and down.
That's one of the things that that's one of the things we're going to talk about too, is that and we talked about it in that last episode about how sometimes people who are their first encounter with an antidepressant actually causes a manic episode.
Yeah.
I'm telling you.
I mean, seriously. And some people, when they think of the word manic, they think anger, hostility, violence, or whatever. But mania doesn't even have to be a entirely negative.
Like, let's clean.
Let's clean.
And
let's
feels so good.
Let's get obsessed about some hobby.
Yeah.
Or
I'm going to buy all the crochet stuff.
Or let's overreact to being happy,
Yeah.
And just go overboard.
And we don't think about how detrimental that can be because, man, that's a high.
Yeah.
And like just Amber just said, I need some of that. Literally, now she's going, man, I need that vibe again.
Well,
but it's dangerous because then you're always chasing that. And then
I need it in a sense when I need to get motivated to clean my house. That's like literally what I need.
Yeah. But the lows, though, that come with that medicine that didn't work were just as equally like low dipping.
Right. So
because there are two sides of the coin. Once you come down from that manic episode, then there's that depressive episode.
Yeah, it's like coming off of Christmas.
I thought you were going to say crystal meth, but it's kind of that too.
Oh, wow.
Yeah.
It is.
Seriously.
It really is.
Seriously.
Yeah.
So
we won't talk about that one.
Okay. I'm not talking about that one. I'm talking about legal drugs here. So anyway, his like I said, his claim is not that these meds don't work. It's that the long-term outcomes, when you actually look at them, don't match what they're selling to the public, right? And I want to read a few of the examples that really popped out about this, and you can come to your own conclusion about this. So a large National Institute of Mental Health depression study found that the 18-month stay well rate, so this is how many patients stayed well after 18 months of being in this study, that 30% for psychotherapy versus 19% for an antidepressant treatment. So 30% of the people who received psychotherapy were still doing well after 18 months, but only 19% of the people who took an antidepressant were doing well after 18 months. And that's not even a long-term study. That's like a kind of a midterm study to me. Schizophrenia outcomes in a study by the World Health Organization across the they did across multiple nations, found that there were better long-term outcomes in some poorer countries like India and Nigeria, where only 16% or less of the patients stay continuously on medications versus higher income countries like the US and some European countries where long-term medication use was standard. So the people in these poor countries who did not have necessarily full access, or they were taken off the meds after, only 16% stayed continuously on the meds. So that means that 84% of them were not maintained long-term on the meds, and those countries had better long-term outcomes than people in the U.S.
Because here it's not about the outcome, it's about what you're getting out of it during it, the pharmaceutical company.
Probably.
For sure.
Probably.
Yeah.
So let's go on to the next one.
Who cares about the outcome?
ADHD long-term follow-up studies through the National Institute of Mental Health showed that by 3 years, or after 3 years of taking, Ritalin or Adderall or something like that, the use was associated not with improved outcomes, but with worse functional outcomes. Worse.
Oh, we got to make your dose go up because your ADD is getting out of control?
Maybe.
Exactly.
I don't know. But after 3 years, they're functioning worse.
Yeah.
And it includes higher rates of delinquency. So, and the measurable differences in physical growth included a slightly reduced height. So the kids that are taking these drugs have their growth stunted, and after 3 years, they are actually having worse outcomes than if they weren't on the drugs. So that's scary to me. Bipolar disorder outcomes studied by the National Institute of Mental Health showed that antidepressant exposure was the strongest predictor of poor long-term outcomes. And patients that were exposed to antidepressants were nearly 4 times more likely to become rapid cyclers. And that's a rapid cycler is someone who goes very quickly from a manic episode to a depressive episode. Sometimes, within weeks or even days. So normally those episodes are longer, like you're in a manic episode for months, or you're in a depressive episode for months or whatever. But the rapid cyclers 4 times more likely if you've been exposed to an antidepressant. And a lot of times the people who are diagnosed with bipolar disorder are exposed to an antidepressant first, and then they have their first manic episode. So that's scary to me. And I couldn't tell you whether I had manic episodes. Let me back that up. I've had manic episodes. I know that they're not necessarily violent or anything like that, but I, certainly kind of go over the top with some things. But I don't know, because I can't remember if I ever had any of those before I was treated with an antidepressant, or if they only came after that. So because I was treated with antidepressant the first time when Kristen was like a year or 2 old, because I was going through a divorce. And I will tell you, I don't remember how I felt when I took that medication or why I didn't like it, but there was something about it. I think I think it made me anxious, which makes me wonder if that was the start of a manic episode or something.
Yeah.
Because it was supposed to calm me down, but it actually made me more anxious. And so I just quit taking it. And that happened to me a second time after Stephen was born. And I felt like I was having postpartum depression. And the doctor prescribed Paxil for me. And I didn't like it. I didn't like it. And it just made me feel really weird. So I got off of it. The last one I want to talk about is the benzodiazepine research in long-term users. And there's actually multiple studies that the results are quoted here. But multiple studies showed that patients often become more alert, more relaxed, and less anxious when they come off of those medications. And these are, this is a benzodiazepine. I believe that's treating for anxiety and sometimes for schizophrenia. So, and then the long-term use was also associated with, and this is scary, moderate to large cognitive deficits. And that came from an Australian study in 2004.
Cognitive deficit, which would be a gap in being able to make logical decisions.
Yes,
Wow.
yes, yeah. Your cognition, you're not able to understand things. Your decision making is not
cloudy. And I've seen that on Side Effects, cloudy thoughts or something. They don't really
yeah.
They don't really make it
so
explain it like
that. And
brain fog.
he goes on to say that these studies aren't definitive, but when you take them all together, when you look at that, it really, it challenges what they're trying to tell us. If what they're telling us is true, then why do all these studies show something completely different? And I will also state that one of the other things that was really disturbing about this is that even though these studies are known, in fact, most of the ones I'm quoting here were done by the National Institute of Mental Health, they weren't presented to the public. So the narrative that was promoted by the American Psychiatric Association and the pharmaceutical companies was that these are safe, they're effective, blah, 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 blah. And they tried to squash anything that said otherwise, or they just swept it under the rug so that nobody would know. I want to bring up the topic or the part of this that really disturbed me because it affects the children. And it was really disturbing to me because it makes me question the choices that I made with my children's medications and things like that. And Kristen can pop in and probably Amber too, because your mother probably made some of the same choices. So the early origins of ADHD, that's as I mentioned before, the there was really not a diagnosis of ADHD until about the 80s and 90s or so, I think. And what happened, I mean, there were doctors who said things like back even in 1937, there was a Dr. Charles Bradley who had, he was giving Benzedrine to hyperactive children. So Benzedrine is an amphetamine, and he found that
because some hyperactives,
react opposite to those.
like coffee and stuff. Yeah,
right.
Stimulants.
To stimulants, yeah. So it helped them focus. So 15 of the 30 children showed behavioral calming, and they had improved ability to focus on their schoolwork. And so the drug informally became called the arithmetic pill.
Wow.
Right?
Well then.
Uh-huh. And there's always been kids who were the naughty kids, maybe. They were rambunctious, they were overactive, boys will be boys, they got into trouble, but they were just kids. And usually, back in the day, they would outgrow it. Sometimes they would wind up being not so great adult humans, but...
Or maybe they struggled to keep a job because they had a hard time following the leader or...
Right.
Yeah.
But back then, most of the time when you had a kid who was misbehaving, the focus was put on the parents and the way the child was being raised, not on something being wrong with the kid, right? And then back in 1956, methylphenidate, which is known as Ritalin, actually was introduced as an approved drug for narcolepsy.
What?
Yes, I did not know that either.
Oh, wow.
And it was marketed as a safer alternative to the amphetamines because it is a...
because if you have narcolepsy, you don't really need an amphetamine.
Well,
maybe necessarily.
But that's what they were giving them amphetamines to keep them awake,
From
right?
falling asleep,
But this one was an alternative to it, right? And so then they, because they were giving the kids the arithmetic pill, right? So then they started using it to clinically treat disturbed children, and I'm using those air quotes again, who were described as having brain damage syndrome.
Brain damage syndrome.
And they don't really go. So
this kind of makes me think of someone that I know that was born in the 40s who passively called someone who had autism as being retarded because during their generation, that's what they called. That's what they called. Anyone who had a learning disability.
Right.
Our generation too.
Disturbed, is that what you said?
Or
disturbed children. That's what they called it.
Yeah.
Disturbed children. Yes. And then in 1961, the FDA approved Ritalin for expanded pediatric use. And then by the 70s,
I can't believe it's been around that long.
I know.
Right?
I didn't know that
I
either.
It's like a vintage medication.
I know. I was thinking I was like the experimental age of kids.
Well, here's the thing, though. They were medicating them before they had a diagnosis.
Oh, yeah.
Right? Because the ADD did not come around until after that. So in the 1970s, about 150 U.S. children were being given stimulants, 150,000. So
150,000?
That sounds like a lot, but wait till you hear what happens. So in 1980, that was in 1970s, right? So in the 1980s, that DSM-3 came out, right? And they introduced attention deficit disorder as an official formal diagnosis. So until 1980, there was no diagnosis for ADD.
They were still experimenting. Yeah.
Right. They didn't know what caused it, but they knew that this medicine made them calm down and focus, right?
The medicine came first, and then
This has been true of
quote-unquote disease fell after. Wow.
This has been true of every psychotropic disease we have talked about in this book.
They may have had disease after the medication.
Right. And sometimes...
I can't believe that.
The disease came later, and the cure or the cause also came later, because it was a chemical imbalance, whatever. So in 1980, they came out with the DSM-3. And then in 1987, they had a revised vision of the DSM-3, and they expanded that criteria to include inattention, hyperactivity, and impulsivity. So those weren't even part of the criteria for ADD until 1987, right? And then they renamed it attention deficit hyperactivity disorder.
Wow.
Right? So it gave a broader diagnostic category, and it significantly increased the identifiable cases, right? and behaviors that were previously seen as normal childhood variations became a diagnosable disorder. I got to let that sink in for a minute because
I know. I'm still stuck on the fact that
your
I
child
grew up
likes
in the
to
generation
run around
where
and have fun, so we're going to diagnose them as ADHD.
because you're not acting like an adult.
right.
You're 3 years old. You should be.
Well,
You should
originally it
sit
wasn't 3
still.
years old. It used
Or
to be that
12 or whatever.
they wouldn't even diagnose ADD or ADHD until you were in school. That thing of diagnosing toddlers is a totally new millennia.
But why
But,
do
like,
we need
really,
school
like,
to be
as
the
far as-
diagnostic process?
It used to
well,
be
the
like
school
you
was
couldn't
part of it. Yeah,
That's because
diagnose
the
anybody
school
with
spends more time with their
bipolar
kids than the
disorder until you
parents
were
do.
18.
exactly. Right.
And then now they diagnose kids like in
Prepubescent.
middle school.
Prepubescent.
Yeah.
Right.
Yeah.
But they're literally using the school as part of the diagnostic scientific process.
Yeah.
Because the kids are with their teachers more than they are with their parents.
Mm-hmm.
So they're waiting until kids are in school, and then when they don't behave in the orderly fashion that the government wants to control us in, then they go and say, "Oh, you
Well,
have."
it's not just the government.
I know.
It's society.
I
Yeah.
know. It's society. is the-
And as a teacher,
monitored
we
by the
have to
government.
fill out those observations.
Yeah, you're
Well, like,
forced to tag
every-
people.
Well,
now.
At least
and
once
I
a
get
month,
it from
I
the-
have to fill out observations.
From
of
the
that
teacher's point of view, you need to maintain control in the classroom. And if you've got a kid that's always cutting up and disrupting the class, you want something that will fix that because you need to maintain the order. It's true. But back in the day, they would send the kid to the principal's office. He'd get paddled. He'd get suspended. His parents would take care of the situation, and it would be over, and that's not the case anymore. So now they're calling all of this a disorder. What also happened at this time was CHAD. I think y'all have probably heard of CHAD. It's children and adults with attention deficit hyperactivity disorder.
Oh, wow. I'm doing a
Okay.
case study on somebody named Chad.
Oh, wow.
But for my class.
This was it's CHADD, children and adults with
Oh, yeah, I've
attention
heard of CHAD,
deficit
yeah.
hyperactivity disorder. It was created to promote awareness of ADHD as a medical condition. So here's the kicker there is CHAD, which is supposed to be an advocacy group that promotes public awareness for attention deficit disorder and everything. It was actually funded in part by Ciba Geigy, a pharmaceutical company.
Oh, interesting.
And they did so to promote their own interests in this, right? So CHAD successfully lobbied for ADHD recognition under the Individuals with Disabilities Education Act.
But it was pushed by a pharmaceutical company.
It's really pushed by a
It's
pharmaceutical
under the
company.
disguise or a mask of
Right.
wow.
The pharmaceutical company needs it to be a
a
disability.
thing so that they can push the medication.
Right. And the consequences of this were that eligibility for federally funded school services, and this was in 1999 they did this, and increased institutional identification of ADHD in schools. So those were two consequences of that. The diagnosis patterns are often driven by teacher reports. Like Amber was talking about, she has to fill out these reports. It was a teacher who first came to me and said, I think Kristen might have ADD.
And see, that was wrong right there.
Well-
like, we're not supposed to do
Well,
that.
here's what happened, though. She told it to me just kind of in passing as a trying to help me help Kristen. She didn't say she
was trying
had
to
it.
help herself.
She didn't say she
Exactly.
had ADD.
I think
She said,
Yeah.
You
It's
might
a way
check
how
this
you-
out. You
Oh,
might
yeah.
check this out.
I can do the same thing on a phone call with a patient.
She's
I can't
like,
diagnose anything, but I can point them in the right
Let's see
direction.
if we can get Kristen medicated so she won't bother me anymore.
Well, probably. Well, Kristen was
Subdue this
Kristen was-
patient or
Kristen
this
was having
subdue
trouble
this
in
child.
school.
child that I can't control.
Kristen was having trouble in school, and so anyway, she tells me this,
having trouble.
and then later when I talked to her about that, well, your grades were bad.
Why?
Yeah. I don't know.
She's
She
a
was
teacher.
bored.
Probably bored, but
Kristen was bored.
But here's the thing, when I
class
came
sucked,
back later and
probably.
talked to her about it, she says, "Oh no, you can't ever tell anybody I told you that."
Yeah, she's
I'm not
covering her
supposed.
tracks.
yeah. You could have gotten her so bad for suggesting that.
Oh, I know.
Oh, you could have
Now
gotten her
you
fired.
know, but yeah.
You could have sued her. Like that is not something that we're supposed
That's another
to do.
system that's bad,
But
Amber.
that is where most of the diagnosis
That's what I'm
start.
saying. The
They
diagnostic
do.
tool is the school system.
They start that process usually.
I'm not saying like
Well, I
your
mean, like,
institution
so we
is
just
bad.
they give us a questionnaire and we fill it out.
The pharmaceutical
then-
company is probably the one that makes the
Right,
questionnaire.
and then give it to, and then I give it to a higher power, and the higher
Catalogs it.
authority
catalogs it.
takes it and does whatever they do with it. I have.
Well, who
like,
knows what they do with it? Maybe they reach out to the
they
parents.
give it to the
maybe not.
government.
They put it in
Yeah.
the pharmaceutical database so they know
Right.
which commercials to play on our phones
Who knows?
now.
Right.
Who knows?
I
But
don't know.
but a Harvard review of psychiatry in 2009 pointed out that only a minority of children with the disorder exhibit symptoms during a physician's office visit.
Right.
And we've talked about this
It's like
before
when you have
about
a cold, you don't have
Right.
symptoms.
All
When
of a
you
sudden
actually
you're
go
not
to the
sick at the
doctor.
doctor. Yeah, that's literally what happened when I went to the neurologist, and she told me like, we don't have a tool that measures that chemical
But you're
imbalance, but I can run these tests.
right, but those tests are not
Yeah.
indicative of
know.
your
Yeah.
normal operating.
She put me in this little closet, this soundproof closet with a computer screen that was like stuck to the desk, like it was in the desk.
Okay.
Like those old school Pac-Man games, right?
Oh,
We're
yeah.
sitting
Okay.
at the table and it is the game. And the light was off, so there was just this screen that was like Pong. It was like two-tone.
Sounds like the start of a horror movie.
Yeah, and I'm sitting in this dark, quiet room, like, what do you call that? Like, it's like, blocked all of my other, senses, right? So all I had was,
Sensory deficit.
yes, all I had was this screen with, like, this dot that lit up, and I had to push a button every time the dot lit up. Well, I'm like, ooh, this is a game. I'm gonna master it. And I played the game and I scored like the highest score. And she was like, wow, you definitely don't have ADD because you had extreme focus. And
But
I'm like,
here's
well,
the-
you just put a game in front of me. Of course
And
I
that
did.
the other question about that is because one
Like
of the
she
symptoms
didn't want me to have ADD.
one of the so-called symptoms of ADHD is not lack of focus, it's lack of control of your focus.
Yeah.
So some
Yeah.
ADHD patients
They took everything out of the room that would
could
give me.
distract you
Yeah.
and put you in a situation where you could hyper focus, which some ADHD patients
Have
do.
great ability to do.
hyper focus.
I'm like, you put me in the perfect conditions to say that I didn't have something by eliminating the ability for the part of me that flounders in
Right.
that to be there.
Right.
Yeah,
So-
I don't know. It was weird. I felt like it was a very disadvantaged test. But go on.
I think it was really. I think they're really weird too. But when you were a child and we had, I can't even remember all of the tests that they ran. They ran so many tests. So we had family therapy with a therapist or a social worker. I think it was a social worker that we had the therapy with. You had
Individual
therapy with the psychologist. We had a neurologist who examined you. He did things to determine your, like your coordination, trying to see if your brain is functioning on both sides the correct way, right? There was also a general pediatrician, I believe, who did tests, like Dr. Marsh. I don't know if you remember him. Because he did things, he looked at your allergies and
I was
things
about
like
to say,
that.
he made sure my sinuses weren't a problem that made me distracted because I couldn't breathe or whatever. Yeah.
And different things like that. So you're thoroughly checked out. And then I had a huge, thick packet of questions that Dad and I both filled out with all these questions about whether you slept at night, what age you were when you slept at night, your behaviors at home, things like that. And all of those questions were asked in multiple ways in multiple places in that questionnaire, just to make sure that it wasn't subjective, like
and that you guys weren't.
Well, and to make sure that the way that they asked the question
wasn't misleading or forcing
me to do one answer or another, right?
Yeah.
And then the teacher also had a similar packet, and then we had to give them all your grades and all that kind of stuff, and they gave you achievement tests. They gave you an IQ test, I believe. I don't remember everything. And so when they did all that, they compared all those things, and that was when they determined by eliminating, this is what they told me, that in eliminating all of the other possible causes, then they could diagnose you with having ADHD. Or actually, they just called it ADD at the time. So they didn't, the hyperactivity was not part of the diagnosis. And at that time, they were still kind of promoting this story that girls more often had ADD, and it was boys who more often were hyperactive, which is not true.
So
because
silly.
you could be totally hyperactive too. If you're sitting there tapping your foot all the time,
I'm not climbing up a tree and jumping the fence, but I am like fidgeting and
standing on your head to read your school homework.
Yeah.
Yes. I mean, literally, she was standing like on her head to read. So,
well, gee, Kristen, no wonder.
I know, right? All the blood went to her
no
head. That was
wonder
the
they
problem.
thought you were weird.
So, and she did have other
My
things.
dad used to say, butts in the air, say it ain't fair, butts in the air. Because I literally would always have...
She would sit on the floor, and she would put her head down like she was going to do a headstand, but she was still kind of on her knees or whatever, and her butt was sticking up. And she's reading with her head upside down, whatever. So, yeah.
Well, see, so when I was Kristen's age, both of my parents worked for the state hospital.
Right.
So, therefore, they were anti-diagnosis because they had seen,
extreme cases.
The extreme cases of humanity. So when I was in college and diagnosed with bipolar disorder, my mom cried.
Yeah, you've talked about that before.
She was like, no, that can't be. I've seen bipolar disorder, and you don't have that.
Right. Because she saw the extreme cases, the people that are hospitalized. So, yeah.
My mom didn't even want me to be diagnosed with gifted. And I very... not to toot my own horn, but I very well was gifted. I was so bored in school and everything like that.
I think that happens to a lot of ADD kids, and that's probably why they fidget too. Yeah. They're bored.
And so, the teacher wanted to put me in the gifted and talented class, and my mom said, no, I don't want that.
Right.
They probably
She just wanted you to be with all the rest of the kids and not have some weird spotlight.
Well, see, and by the opposite of that was I wanted them to put Kristen. I wanted them to put Kristen in the gifted class because
in any way.
Yeah, she had been tested when she was 4 years old.
I remember that.
And she had a very, very high IQ, and they said you need to get her in school early and keep her occupied with lots of things because otherwise she will lose interest, she will get bored, and that's when she's going to get into trouble.
She'll get ADHD.
Right. Well, they didn't even say ADHD then. I
was joking.
No.
Yeah.
But seriously, she had family members who were likewise gifted who, when they were in their teens, got into a lot of trouble. And that's the theory, is that's what was happening. So
the boredom is real.
I wanted them to put her in a gifted program so that she would be challenged and interested in the things. And I could not get the school to do it because one of the tests, and I don't remember what it was something where you took the question very literally. I don't remember what it was, but they said, oh, she doesn't have or she's not gifted, even though she had a really high IQ and her academics were pretty good at that point because she was already medicated at that point, and she had achievement scores, like the STAR test or what, I can't even remember what it was back
TOS
then.
And
TOS,
CAT.
yeah. CAT tests, yeah. All of those were really high. She did really well on them. But this one test was like a creative test or something. I don't remember what it was.
Oh, and so I took it literal like a test.
Yes. And so they said, no.
I've done
Put a
that
test
before.
in front of me and make me streamline my thought process to be literal test taking.
Right.
And then you put another test in front of me to test my creativity, but it's the same format. So how are you going to get creativity after you've forced uncreativity?
Yeah.
Yeah.
So that's what's horrible about
test
these
taking,
tests.
standardized tests.
Standardized testing is awful.
You are very much smart and you are very much gifted, and for them to give you that test and be like, she's not gifted, that's messed up.
I know, right? But she didn't, and I will tell you this also, I think she missed the criteria for getting in by 2 points. So it's like, you can't do a little leeway there? 2 points. That's close enough to say that if she had a bad day or answered one question wrong, it could have made or break the difference.
And that's where
that's
like
any
a
test.
Creativity test, and then to say that something was wrong.
Yeah.
That's kind of weird
It
too.
is kind of
That's
weird.
a weird scoring
There
method.
is no wrong in creativity.
Exactly.
Yeah. So, okay, so
fools.
So during this time,
Honestly, though,
I know it's really
diabolical. Like now, I become a supervillain because they didn't
Because
let
I'm
me
not
be creative.
creative.
Yeah.
I am a supervillain.
Yeah.
Okay, so I want to get back on track here.
Creative.
So the prevalence in prescribing, when all this diagnosis was happening, was growing and growing and growing. At the same time, the rates of prescribing these Ritalin and other medications started growing as well. So remember, I told you that in the 1970s, only 150,000 kids were taking stimulant medications, right? Or I think it was amphetamines was what it said. Mm-hmm. No, it was stimulants, all stimulants. So by 2007, the rate was 3.5 million U.S. children.
3.5 million. So we went from 150 and see, to me, like you said, that's not a lot, but that's a whole town. Like
Honestly,
the population
that's
of
the city
this
of Dallas. That is the city of Dallas.
Well, but the 150,000 people is like
the
pretty
city of my
Lubbock.
suburb.
That's
or
like
Yeah.
Denton.
yeah.
Yeah, that's
right.
like every single person being on that test, and now it's every single person in the major
The whole
metropolitan area.
The whole county, right?
Yeah, that's crazy.
So it's crazy. That's I don't know what the math is on that. If somebody wants to figure out what that ratio is, the
Don't
how many
ask me
fold
to
increase,
math.
I don't.
it's like
I can't either.
500% or something.
Right. But 1 in 23 children aged 4 to 7 were prescribed stimulants, or 4 to 17. Sorry, 1 in 23 children aged 4 to 17 were prescribed stimulants, and U.S. children consume 3 times more stimulant medication than all other countries combined.
Because we are a capitalist society.
Isn't that crazy, though? That's crazy to me.
That is crazy.
They continued, trying to build on that, to validate that biological connection.
Because America is run by the pharmaceutical companies.
it's just all, there's just so much. And like I said, I looked at that and I was like kind of horrified. But I want to talk about like methylphenidate, which is Ritalin.
Mm-hmm.
It is a dopamine reuptake inhibitor. It blocks 70% of dopamine reuptake.
I always thought it was a serotonin, so it's a dopamine.
It's a dopamine. It keeps the dopamine in your brain. It has, get this, a similar mechanism to cocaine, but a longer duration of action. So it acts in your brain just like cocaine.
That's crazy because dopamine is what is pursuit and curiosity and discovery.
Dopamine is what addiction is.
Yeah.
Okay? But it lasts longer. So cocaine has a short half-life, right? It goes in, you feel high,
and then it goes away.
But the Ritalin stays in the brain longer. Okay?
So it's just being on cocaine
a little bit longer, right?
All the time. A little bit all the time.
So long-term exposure, which is what neuroadaptation. So your brain begins to adapt to it, right? The effects of that in long-term exposure are reduced dopamine receptor density. So you have
reduced natural bursts of dopamine.
No? You have less receptors. Okay?
Oh, less receptors.
Yes. Reduced dopamine receptor density, decreased dopamine metabolites, which means a reduced presynaptic release. They're not putting as many out.
Not metabolizing.
Because you've got it all sitting there that whole time. Altered serotonin and norepinephrine systems, and brain function becomes, and I'm using quotes here, qualitatively and quantitatively different from baseline. End quote.
Just different.
Different.
Altered, but not
the
with
quality, the quality and the quantity.
Mm-hmm.
Okay? The short-term behavioral effects, this is in studies of children on Ritalin. In the short term, the 15 of 30 children showed emotional calming. A double-blind study in Ohio of Ritalin showed reduced curiosity. This is where your dopamine's talking to me.
Curiosity and discovery and pursuit.
Reduced curiosity, humor, spontaneity, flattened affect, so you're emotionally bland, and increased passivity and social withdrawal.
So, and you said something about norepinephrine and serotonin. So, because of that, it kind of hinders your ability or receptiveness of those?
Let me see. Let me go. It just says altered. So it doesn't say which.
Because serotonin is contentment, stability, and the feeling of belonging.
It probably maybe it activates more serotonin. I don't know, because he's talking about increased passivity. So you're going to be more passive if you're more content, right?
But then you also said not like that sense of not belonging.
Social withdrawal.
Social withdrawal.
So they're withdrawing.
Not belonging. That serotonin makes you have that sense of belonging.
Right.
If you don't have that sense of belonging, what do? You withdraw.
Well, that's true too. Those were the emotional effects. The behavioral effects were increased solitary play, reduced social initiation, and more passive submissive behavior. Now, taking that in mind, look at your brother who started on the ADHD meds, and he was on Wellbutrin, and I don't think Wellbutrin is an SSRI. I think it is something else.
Yeah,
it is something else. It's not an SSRI.
It's its own category, and it is called, I'll tell you what it is.
Is it a dopamine inhibitor?
No, it is... Hang on just a second, and I'll tell you. It is neither SSRI or MAOI. It is a NDRI, norepinephrine dopamine reuptake inhibitor.
So
Yeah,
right
it
there,
has like
right
a
there. So it's
multifunction
active.
It
type
has
thing.
very little direct effect on serotonin. It works
Right, but it
primarily
is-
on dopamine and
It
norepinephrine.
is affecting the dopamine.
Yeah.
So
And the norepinephrine.
and the norepinephrine, like Ritalin does. Okay. So and look at him. He has historically been a solitary play,
Mm-hmm.
reduced social initiation, more passive submissive behavior,
Mm-hmm.
social withdrawal, emotionally bland.
Yeah.
I don't think it has reduced his curiosity because he's been a lifelong learner, and it hasn't affected his humor. I don't know if it affects his spontaneity or not, but those behavioral effects,
Mhm.
and some of those emotional effects, definitely I see those in him. And he was probably on Wellbutrin longer than you were on Ritalin. Now you were on Wellbutrin also
2 different times in my life.
Yeah.
I was on it as a older teenager, like 16, 17, just for like a couple of years, and then I took it as an adult when I started taking Lexapro,
Right.
like maybe a year after I started taking Lexapro.
Uh-huh.
And then I'm no longer on the Wellbutrin because I was having side effects, and so I stopped taking the Wellbutrin and went back on the Lexapro.
Right. And I don't know if these behavioral effects are the same in adults. He presents them in the section about children.
Mhm.
So, and like I said, when I read that, I was like, oh
But
my gosh, what did I do to my kids?
When you think about it, though, when you suppress things in children, it stems long into their adult life. So think about a kid. All kids like to draw and color, right? I don't know of any kid who doesn't draw something, right? And at some point in our lives, we stop drawing, and it usually is because we get this sense of not being able to draw or not good at it. Not good at it. But if you look at every kid who draws, it's like scary, squiggly hands, not very well controlled, but they get better and better.
Right.
But then at some point in their age, we stifle that part of creativity as being a necessity.
Yes.
And then because they stop, it stunts that growth.
Right.
And if you think about those drugs as being a stunt growth, a growth stunting thing.
Yeah.
And it's not just growing
Not
in like your
growth,
physical
yeah.
growth, but mental development and emotional
Right.
development.
Right.
If it suppresses certain things or molds you into being compliant, then that's where you stop.
Right.
Where you grow, and that's where you're at. So, one of the things, like you were talking about my brother, is that he's always struggled with going beyond that mode of expressing himself, right? He's always just been like very cookie cutter with his emotions.
Yes.
And
Well,
it
he
kinda
has
makes
a hard
you
time
wonder.
putting a
A
finger
word
on
to it.
what his yes.
Yeah. And that's interesting because if you suppress it, then it kind of like
Right.
gets hidden.
If he is emotionally bland or flat,
yeah.
then he doesn't have those highs and lows of emotion. It's so he doesn't.
Yeah.
They're all of his emotions are kind of the same. There are also self-reported lower happiness, lower rates of happiness, increased dysphoria, and negative self-concept associated with negative self-concept associated with medication use. That's from a 1990s study, and those are some of the subjective effects that the kids have reported. So they often interpret the medication as being evidence that they are bad or defective, which we talked about, and they are having to rely on magic pills for normal behavior. And the academic outcomes, it does improve routine, repetitive task performance, and sustained attention in structured settings, but the long-term findings show that it does not improve reasoning, problem solving, learning, and it may impair higher order cognition.
Wow.
There is no consistent improvement in academic achievement, behavior, or social functioning. And then there's often observed symptom rebound after they discontinue use. So, and in fact, even just the day-to-day, once the medication wears off, the parents observe a rebound effect. So the NIM expert panel, after some studies, determined that, quote, long-term efficacy of stimulant medication has not been demonstrated for any domain of child functioning. Long-term efficacy of stimulant medication has not been demonstrated for any domain of child functioning. So, long-term, it is not efficient. It doesn't do. There's no reason to be using it. Some of the other things that were associated with it was worse functional outcomes, increased delinquency scores, lower growth, height, and weight suppression. In a 6-year follow-up, they had worse hyperactivity and impulsivity, oppositional behavior, and worse overall functioning. So it gives short-term behavioral control, but long-term functional outcomes did not improve. And
so, like an antidepressant, it's a Band-Aid, but it's not treating the root issues.
The issues, yeah. And physically, it results in appetite loss, weight loss, growth suppression, insomnia, lethargy, drowsiness, headaches, abdominal pain, motor and vocal tics, hypertension, and a cardiac risk, as there have been rare sudden death reports.
For children having cardiac?
I know, right?
Wow.
Emotionally, there's irritability, anxiety, depression, apathy, mood swings, crying episodes, and hostility. And psychiatric observations were obsessive compulsive symptoms, psychosis, mania, hallucinations, paranoia. And then there are neurobiological concerns like reduced cerebral flow and glucose metabolism. Glucose metabolism.
So, like diabetes?
Type 2 diabetes.
Wow.
Which has grown in the last
it's
30 years.
Multiplied, yeah.
Yes.
So it has cardiac events and hypertension.
Yeah. In animal studies, they noticed a pre-adolescent exposure caused the adults to exhibit reduced exploration, increased anxiety and depression-like behavior, and sexual behavior deficits. So
interesting
in
too
the youth.
Is okay, and so, you just made me think of something like, okay, yeah, they use animals, right, to test it, but
right.
You would never go, wow, my dog has ADD, I'm gonna give them medicine.
You just say my dog is a hyper dog, and it's usually based on the breed.
Why do we do that to our kids?
I don't know. So so that's that part of it, and I wanted to really go into that one really in depth. And then here's another part of the children's story that I wanted to bring to you, but it's crazy because the system increasingly defaults to medication as the first line response, even when there's a sign of trauma or something like that.
Yeah, it's the Band-Aid.
Yes, it is. It really
Slap
is a Band-Aid.
And
sometimes they don't even, nowadays, I've heard of kids being diagnosed by their teacher or being diagnosed by going to see one doctor, and the doctor says, oh, you have this, or whatever. And they don't ever ask about the trauma, just like in some of those earlier case studies that we talked about. They never asked about
inquired about the home life. Yeah.
The home life, or the girl that had a date rape incident, and then she had manic disorders, and stuff. And it's crazy to me. But here's where it really hits home, and that's the foster care system. So, in systems like foster care and residential treatment centers, there is a structural problem. Medication becomes a management tool, just like I was talking about in the hospitals with adults. And it's not out of malice; it's just because of scale. The overburdened systems favor interventions that reduce disruption. We're back to the school thing too. Reduce aggression and stabilize the behavior really quickly. So if a kid comes in to the system and they're crazy and screaming and kicking or fighting or whatever, they're going to take them and have them evaluated, and they're going to put them on something to calm them down. Mm-hmm. And it creates this feedback loop. So that a distressed child enters the foster care system. Okay, this kid is already traumatized because they're not being taken away from their parents because everything's normal. Right. They're being taken away because they've been in a neglect or an abuse, or their parents have to relinquish them because the parents aren't able to take care of them sufficiently. Mm-hmm. So then they give them medication to reduce the visible symptoms, right? Mm-hmm. The system reinforces this medication use, and the child then remains on long-term polypharmacy is what they call it. So they'll they just keep giving more and different medications. There is an example that I wanted to talk about, but I'm going to talk about it later. The way they are one of the options for treating it, but I just want to talk about these. I don't think this is right that we are just medicating these people, and it seems to happen that the minority populations are the biggest victims of this institutionalized policy, right? So a black young man enters the foster care system, and he's angry because he was taken away from his mother, or his stepdad beat him or whatever, and he's angry, and he lashes out because he's in this strange place and not being, and instead of getting the help he needs, they just medicate him until he's stupid. And in Whitaker's book, he gives examples of some of these kids that were so over-medicated in the foster system that they barely functioned.
Wow.
And so it really just, it really bothered me that was one of the things. So, and y'all have mentioned several times that, the money is the big part of the issue. And I want to talk about that. So between 1985 and 2008, psychiatric drug sales rose from approximately 503 million. Mm-hmm. Okay, this is in
the 80s.
A 23-year period. Mm-hmm. Okay, 23-year period. The drug sales rose from 503 million to 24.2 billion.
Yeah.
Billion.
And you can't say inflation is the reason.
No,
because that's not the same scale.
No,
that's rate increase.
That's a 50-fold increase. Mm-hmm. 50 times it increased, mm-hmm. right? The total psychotropic drug sales exceeded in 2008 $40 billion a year. $40 billion. Roughly 1 in 8 Americans was taking a psychiatric medication.
Wow, so we went from 150,000 test students to 1 in 8.
Well, this is all Americans.
All Americans. That's what I'm saying. Like, it started off with this small little group of people. Now, then you said 3 million people. Now we've got 1 in 8 Americans.
Right.
What's America's population?
I don't know. I really don't know.
In the way high upper millions.
The corporate growth, huh?
Probably billions.
I don't think we're.
In the billions yet. China probably has a billion or more. Corporate growth mirrored this trend really mirrored this trend. Eli Lilly grew from 1987 a $2.3 billion revenue. That's how big they were in 1987. $2.3 billion in revenue. Can you imagine? $2.3 billion. In 2000, just 13 years later, it was $10.8 billion in revenue.
In revenue.
Revenue.
That's revenue.
Revenue.
That's what's left over after they paid everybody.
Well,
and
that's one company.
Keep the company growing.
That's one company.
Yeah.
They have psychiatric drugs like Prozac and Zyprexa, and they drive the majority. Those are two of the biggest ones. I think I read in here somewhere, and I don't know where my note is. Prozac was like the number. I'm guessing, I will correct this on Heard It on the podcast if I find otherwise. Prozac is the third most prescribed medication in the United States.
Really?
Yeah.
Not cancer medicine or heart disease medicine, which are the two highest leading death.
Well, I don't know. We don't know what number 1 and number 2 are. It is the third. It's number 3 on
right.
that list,
Hopefully those other two are, but look at how many different types of cancer and different types of heart problems people have. Diabetes is also one of the top number 1 causes of death.
Right.
So how come those aren't? Yeah, I don't know. That's crazy.
So Senator Charles Grassley did an investigation, and I'm going to find those here somewhere. Are they here? This was in 2008. Senator Charles Grassley led an investigation into the amount of money that pharmaceutical companies paid for what they call the key opinion leaders. Those are those. Remember when we talked about the APA annual meeting, and people go to these symposiums and they're put on by the pharmaceutical companies, right? So they pay these speakers, these keynote speakers and whatever, to get out there and sell the ideas, right? And so this senator wanted to investigate how much these psychiatrists were getting paid to be hired as speakers at these symposiums, because academic psychiatrists regularly receive National Institute of Health grants to perform, towards their institution and stuff, to perform research, right? And there was a ruling that whatever they make, if they have to report everything that they make or that they are paid by the pharmaceuticals, so that it's so that their research stays uncontaminated, right? And if they get more than $10,000 a year, it's considered to be a conflict of interest. So if a pharmaceutical company is paying you more than $10,000 in a year, or combined are giving you more than $10,000 in a year, that's a conflict of interest, and you're not supposed to receive it. But when he reviewed the records, he found that not only were most of them making much more than $10,000 a year, they were also hiding it from the schools.
Wow.
Yeah. Okay. So I'm going to give a couple of these and I'm trying to hurry through this because it's like, crazy. But from 2000 to 2007, the chairman of the psychiatric department at Emory Medical School earned at least $2.8 million as a speaker and consultant for drug firms with GlaxoSmithKline alone, paying him $960,000 to promote Paxil and Wellbutrin. That's almost $1 million to promote that one drug.
And he's
not supposed to take more than 10,000, right? Mm-hmm. So here, the psychiatrists are just as corrupt. He is also the co-author of the APA textbook of pharmacology, which
so
is
he's
the
writing
best-selling
the book that they're following, as the guidelines and standards.
Yes.
Yeah.
In December of 2008, he resigned as the chair of their psych department because he failed to inform Emory of his drug company paychecks. Another professor of psychiatry at Emory
got caught doing it.
Yeah, probably. Another professor there received $250,000 from GlaxoSmithKline. That's a really hard word to say. In 2000 and 2008, partly to promote the use of Paxil by breastfeeding women.
What? So they were introducing it into the blood
Breast milk?
system. Yeah.
Yes. Emory reprimanded him for failing to properly disclose these payments to the school. So not only was this I think a questionable thing to be promoting that in the first place, but also he lied. He was like getting money under the table and not reporting it. That's member.
Why there's laws against that now, because someone caught him dirty.
Well, they already were laws against it, and they were still
really?
getting.
Oh, wow!
That was the thing. Because they were receiving those federal grants, they had to report that, but they weren't. They got caught because the senator got kind of suspicious about it. Another member that got money from GlaxoSmithKline was the former director of the National Institute of Mental Health. Hello, there's where they are in the drug company's pockets. The company paid him $1.2 million from 2000 to 2008, mostly to promote the use of mood stabilizers for bipolar illness. He is the co-author of Manic Depressive Illness, the authoritative textbook on this disorder. He was also the longtime host of a popular radio show on NPR. He's been a speaker consultant for a number of other pharmaceutical companies, the $1.2 million being only what he received from GlaxoSmithKline. And in an interview with the New York Times, he explained that he was only doing what every other expert in the field does. I could go on and on about these. It's disgusting, as you can well imagine. And they're all in the book. I just, I picked those out because I thought that was worth sharing with you guys. And
I think as far as like the most prescribed SSRI or depression-y type medicine for those types of, I think Zoloft has passed.
Well, and I will say that this book, I think the records in this book only go back to 2008 because it's not a new book. So
okay, yeah.
So
I was
so
just
Zoloft,
looking up like 2025 trends. Yeah,
right.
that
Yeah. So Zoloft may have passed that.
Has passed it. Yeah.
Yeah. So so anyway, that this is dirty stuff. But here's some of the stuff that these doctors and the drug companies and the National Institute of Mental Health were trying to promote. So the National Institute of Mental Health actually launched a public education effort called Depression Awareness, Recognition, and Treatment, DART. I'm not sure if they pronounce it that way or not, but it's DART. And it was explicitly designed to increase recognition and treatment rates of depression, okay? And one of the things that they emphasized they had all these campaigns, like public TV campaigns and ads and newspaper articles and magazine articles, and their consistent message was that depression is common, depression is biological. There's that questionable thing there again. And depression is treatable, which we believe it is, right? And then once it kind of became stable, it became this set thing. Depression is a mental illness. Medication is the way to correct it. long-term treatment means prevention of relapse. And they just, really honed in on those stories. And that's what the public has come to believe. But the critique from Whitaker is that this narrative did not fully incorporate the long-term outcomes, the withdrawal effects. I mean, how many people... I've known several people who just suddenly stopped taking their antidepressants because they didn't know that you just can't do that, right? It actually often causes a rebound effect that is worse than the symptoms the person had before they started taking the antidepressant or whatever it was. And they do it because they don't know that you actually have to taper off of it very, very, very slowly. He also did not, they also, these things from the National Institute of Mental Health and the APA also did not include any of the comparative international data from other, like other countries have actually banned a lot of the medications that we're still giving to children. They don't let them prescribe it for children for the various reasons that we've talked about. And they don't talk about functional recovery metrics either. So what he does talk about towards the end of the book, and we're getting close to wrapping it up here, and I thank you for being patient with me, and this is kind of the crux of the whole idea, is that there are alternative models, and I like a lot of these. They seem to really work well. Whitaker talks about one major counterexample that is really awesome. So in Western Lapland, which is part of Finland, there used to be a huge number of people who were diagnosed with schizophrenia. There are about 70,000 people who live in Western Lapland. And during the 1970s and early 80s, 25 or so new cases of schizophrenia appeared each year. 25 out of 70,000. So it's like double and even triple the norm for other parts of Finland. So we don't even know why that was happening there. But those patients regularly became chronically ill. But now those outcomes, those long-term outcomes in Western Lapland are the best in the entire Western world. And this region now sees very few cases of schizophrenia. And it all comes down to a doctor, and I cannot say, I can't say these Finnish names. So I'll just say his last name, I think it is. In 1969, Alanen, a Finnish physician who had psychoanalytic training, arrived at the psychiatric hospital in Turku, a port city in southwest Finland. Back then, a few psychiatrists in the country thought that psychotherapy could help schizophrenics. So they were just medicating them because they didn't think it was any good to give them psychotherapy. But he believed that the hallucinations and paranoid utterances of schizophrenic patients told meaningful stories. And so he felt like the hospital psychiatrists, nurses, and staff just needed to listen to the patients. He said it's almost impossible for anyone meeting with the patients' families not to understand that they have difficulties in life. They are not ready to be adults, and we can help with this development. Over the next 15 years, he and a handful of other psychiatrists developed what they called the need-adapted treatment of psychotic patients. So every treatment had to be case specific. So it wasn't just a cut and dried whatever. And some first episode patients would need to be hospitalized and some others would not. Some would benefit from low doses of meds and some did not. But they settled, more importantly, on a form of group family therapy, of a particularly collaborative type as the core treatment. And that was the need adapted treatment. So any decisions about the patient's treatment were made jointly at these meetings with psychiatrists, psychologists, nurses, and others trained in family therapy. And they served on these 2 and 3 member psychosis teams, right?
Mm-hmm.
So, and then they would meet regularly with the patient or his family, and his family. And during those meetings, that's when they made these treatment decisions. So the
Like
patient,
a 5014.
or 504,
Yeah, or
Yeah.
whatever it's called. Oh, 50.
or an ARD.
Yeah,
An
ARD
ARD,
meeting.
yeah.
Yeah, that's what I was
Except the
thinking of.
kids aren't in on the ARDs.
No.
So
yeah,
but
because they're children. But as a patient, you get
Yeah.
to be a part of the
right.
diagnosis.
I mean,
and-
I think that's important especially as an adult.
I mean, that's like the ideal medical system is that all your doctors work together. They refer you out to go see a specialist, and then a specialist is supposed to provide the feedback, but the doctors don't actually work together. The
Right, they
only
don't.
way you get that is if you go to one
Right.
of those really specialized, expensive wellness centers.
Right. Well, and what, like I said, the patient and their families are also part of this narrative.
Right.
So they focus on the conversation, and they focus the conversation on the patient's past successes and achievements, and they help them to kind of strengthen their grip on life rather than focusing on their psychotic symptoms. So they weren't really even trying to get their psychotic. We don't care if they have hallucinations. Who cares, as long as they can function well in society, right? And so they did this for several years, and they found that 61% of their schizophrenic type patients that were treated from 1983 to 1984 were asymptomatic at the end of 5 years, and only 18% of them were on disability. That's an incredible cure. I don't, if it is a cure rate, right? And eventually Finland decided that psychotherapy could help those patients, but they were still trying to use the antipsychotic meds. And eventually when Alan and they actually tried this at multiple different facilities. I think there were 6 facilities, and 3 of them, the patients came into the program unmedicated. So they had no medication at first, and they weren't put on medication until later in their treatment. But when he retired, they went right back into the being that biologically oriented instead of, socially or psychologically oriented. And so they went back to giving the drugs again. But in Tornio, also, Tornio was one of the other locations, one of the other hospitals. There's a hospital in Tornio, and they also had the unmedicated patients, and so they kind of took off on that same thing and started the need adapted treatment when they heard about it. And so they would hold these open meetings, and they talked about how when the patient is there in front of you, your language even changes. You talk differently about them than you do when they're not there. Mm-hmm. And I thought that was really cool. But in this study, the long-term outcomes for all first episode psychotic patients through 1992 to 1997. So after 5 years, 79% of the patients, schizophrenics, mm-hmm. were asymptomatic, and 80% were working, in school, or looking for work. Only 20% of the patients were on government disability.
Wow.
That is an incredible, incredible result. So I really liked that as an alternative model. And one of the key things about it is they developed this open dialogue system. So within 24 hours of a patient or family member or teacher or boss, whatever, coming forward and saying this person's behavior needs to be looked at, right? They had a rapid response. So within 24 hours, they would put together a team and respond to it. That is huge, right? The family was involved from the first contact. It was all collaborative decision making, minimal early medication use, and the whole idea was it was an emphasis on dialogue and social context. And they had such a high rate of functional recovery. It reduced the hospitalization. There were low chronic disability rates, and many patients returned to work or school. So I think that one's fascinating. There's another one where I think it's called Seneca. It was a foster home in California, and they also do not medicate. So when the kids come there, it is like a last resort foster home for the worst of the worst kids, right?
Oh.
So they've already been kicked out of all of the other group homes or whatever, and the whole foster system pretty much, except for this is their last chance. And when they take them in, they actually take them off of their drugs immediately. I mean, it's a weaning process, obviously, but and they say that the kids are afraid to go off the drugs because they've been brainwashed pretty much to think that the drugs are what's controlling them, and that they might get out of hand if they're not on their drugs. And some of them act out, and and they have to deal with that, for a little while. But eventually, once the drugs are out of their system, they start teaching them coping mechanisms. And the whole idea is that these kids are having all these problems, but they're never learning the coping mechanisms to be in the real world. Because you can't teach someone who is doped up, right?
Right.
So by taking them off the drugs, then they can teach them those very real coping mechanisms, and they can function in society without their medication. And the results, they don't have any studies that show, because they haven't done any studies to see what the long-term results are. But the staff there can tell you a lot of stories about various and assorted children who came through this program and how well they're doing. So, so that I thought that was a great alternative option also. So that's basically the thing. Whitaker again doesn't say he doesn't want any kind of meds. He agrees that meds can sometimes be used effectively, but the problem is that the public isn't really aware of the options. They're often never given an option. They're just told this is what you have to do, and I think that's the big picture there. So we know that these psychiatric conditions, whether they're a disease or just a description of behaviors, we know they exist because we've seen them ourselves, or we are them ourselves, as the case may be. But the idea is that we need to be really aware and just watch out for the rhetoric that's being put out there, because that simplified public narrative that went out really kind of covers up a more complex scientific reality, and that long-term outcome data doesn't really match most of the public's expectations for those medications. So the consequences of these medications and these choices are very real. They've reached children, they've reached foster systems, they've reached into our schools. They've affected entire generations of kids and now adults. And what's really uncomfortable is that not necessarily that psychiatry is wrong, but that the system is internally inconsistent and maybe not necessarily to be trusted. What do you think?
Oh, I think I've pretty much told you what I think about the whole thing.
Yeah, the medical industry sucks. It's all about money. That's like the basis of the whole book.
Well, to me, it feels like...
I feel like they rushed to judgment about things.
Not even rushed to judgment. It's like, this is established, and in order for this to exist, that needs to happen, and this needs to happen, and that needs to happen. And it is a circular reference of this entity requiring the other entity to exist in order for the other one to exist. It's
right.
a recursion effect of
right. It kind of is.
It really is, because the DSM needs the doctors to validate the disease,
right,
in order to be in the DSM. The pharmaceutical company needs the DSM to validate the disease so that they can diagnose the pharmaceutical. The pharmaceutical company was already creating the pharmaceuticals to treat
right.
the disease that
and
hadn't been.
The psychiatrists need the DSM and the pharmaceuticals to maintain their authority in that realm.
And somewhere they throw the patient in there, but the patient isn't part of the cycle. The patient's in the middle of it. And they're all running circles around us.
Right. And I think, one of the things that I kind of glossed over and didn't talk about, and I'm not going to because it's in the book, but was how they...
But she is anyways.
Well, no, I'm just going to mention it and not... I'm going to mention it and not...
What you're saying is the medical industry sucks.
Well, but the thing
Kristen
is
just said it in like 20 more
there
words.
There were psychiatrists who believed that psychotherapy was part of the answer, and there was a lot of those mentioned in the book. But in order to maintain that medical model, they had to shove them out of the industry. Yeah. And so they shunned those people. They literally
even within the foster care system, if you think about it, the standard foster care parent, and I am not stating that I'm not disrespecting them because they are a superhero of their own kind, but they are not all 100% capable of being clinically, a therapist.
Yeah.
Right? They are not therapists, but these children.
So they're just going, these kids come to them.
Homes that are, what do you call that? Like rehabilitative home. And that's the whole point of a foster care system, is that they go to a family and they're in a warm, welcomed environment that's safe, but they are also not getting always the...
Well, but a lot of times they come into that home already medicated.
Yeah. And so, and what ends up happening is that, again, that counseling piece is just being squeezed out, wedged out, bypassed.
Right. And they wanted to shut those people up because if it's something that can be fixed by counseling, then that means people won't be buying their drugs.
Yeah. Right. And it's all, the pharmaceutical company needs the cycle to happen in order to stay. Yes. Right.
And this is true of all like industry and government organizations and it is a vicious cycle.
And it goes back to that whole systematic problem that people go on these drugs for temporary relief and then they stay on them because the pharmaceutical company needs you to stay on their drugs. They don't need people to be cured and move on.
Right.
They need everyone constantly taking their drugs in order to maintain their
and he talks about in the book how many hundreds of thousands of dollars a single patient generates in revenue because of the medications they're on.
Yeah.
It's crazy. It's
I was doing some math, And because we were talking about the population, there's like 342 as of 2024. There's 342 million people in the U.S. 1 in 8 people is 140,000 something, 42 million. Sorry.
Okay.
People on just that type of drug.
Just that
type of drug.
Right.
And the pharmaceutical companies make $60 billion a year in revenue, not just, like solid profit, right? That's what's left over afterwards. $60 billion.
Well, I don't know if revenue, I don't think revenue
and
net.
profit are two different things, right?
Right.
So but I'm talking about like
revenue
extra
is
cash
the money
overhand.
that came in.
Yeah.
The money that came in. People the money that people paid to buy that medication.
Right.
Yeah.
So they make on average 42 million people taking or getting those type of medicines. They spend $1,400 a person, which is $60.9 billion a year.
Yeah.
I did the math because
for one drug.
Yeah, for one drug.
One drug.
And that's not even talking about, being on
multiple drugs, which a lot of them
Wellbutrin and Lexapro.
Right, because a lot of times what happens is they get on these drug cocktails because one drug gives them this symptom, so they give them another one to alleviate that symptom, and then they give them another and another. So
to conclude, the pharmaceutical industry sucks. That's the conclusion.
Well, I agree. I think it does. And so, yeah, but I just wanted to share all these things because it's one thing to say that they're corrupt or whatever. It's a whole different thing to share the facts, to give the numbers, to show the actual results. And that's why I wanted to share this book. As I said in the first episode, this was a life changer for me because I was one of the people that bought into the whole
neurochemical imbalance.
Yes, and I thought, okay, the meds are helping, and you know what? Okay, so what if I have to be on it for the rest of my life? It helps. But now I'm wondering if it really does, and now I'm wondering if some of the other symptoms that I started having are caused by these meds, and actually I found out that some of them were. So that's where we're at. I would love to hear from our listeners. I could talk about this for hours. So if you want to send me an email or something like that, or get over on our MMC Chat Facebook group, you can just look for MMC Chat as a group. And you'll find us there, and you can send us messages, and I would be glad to have a conversation with you. And what are we talking about next week, Amber?
We're going to be talking about next week how to make yourself do the things that you don't want to do.
Ooh,
and that could be really interesting because I do a lot of things that I don't want to do.
So do we. So do I. Like finishing that book that we just finished.
Exactly.
Oh, actually, I did want to do it. I just didn't want to do the work. But
that's the essence.
That's the idea. Yeah. Okay. Well, it was great being on here. I hope this one wasn't too long. Amber's like giving me the eye roll.
Dude.
No. And we appreciate you sticking with it. And I hope you got something out of it, whether you believe it or you don't believe it. We'd love to hear from you. And you have a good week. We'll be back next week.
Bye.
Bye.